What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about strokes, ischemic and hemorrhagic. We talked about shock, including neurogenic shock. We talked about the Glasgow Coma Scale. We talked about dopaminergic pathways in the brain. We talked about neuroanatomy, physiology, pharmacology, and we're talking pathology now. In previous videos, we talked about Guillain-Barré syndrome, multiple sclerosis, Myasthenia Gravis, and Lambert-Eaton Myasthenic Syndrome. Today, we shall compare between the two, Myasthenia Gravis and Lambert-Eaton Myasthenic Syndrome. Both of them are autoimmune diseases. Myasthenia has antibodies attacking the post-synaptic muscle, namely the acetylcholine receptors on that skeletal muscle. But in Lambert-Eaton Myasthenic Syndrome, the autoimmune attack is against presynaptic calcium channels. I've told you before that ptosis or droopy eyelids, whether unilateral or bilateral, in a young person is myasthenia gravis until proven otherwise. Click the like button, click the subscribe button, and let's get started. There are two neuro playlists on my channel. One is for neuroanatomy, which has more than 45 videos, and one for neurology, which is basically everything: anatomy, physiology, pharmacology, and pathology. We've talked about myasthenia in its own video, and I've told you why it was called myasthenia gravis. Myo means muscle, A means no, stenos means strength. So my muscles have no strength. This is myasthenia. Why gravis? Gravis from gravid uterus. A gravid uterus is a pregnant uterus. Because back in the good old days, which were not so good, people thought that myasthenia was caused by pregnancy. But that's not true. As for Lambert-Eaton Myasthenic Syndrome, it is a paraneoplastic syndrome for the most part, usually associated with small cell lung cancer. And we have talked about it in its own video. Today, let's compare between the two. Okay, here is the central nervous system, here is a peripheral nerve, here is the neuromuscular junction, and here is the muscle. Some diseases that cause muscle weakness are due to a problem in the central nervous system, such as multiple sclerosis, where you have demyelination of the central nervous system, brain, and spinal cord. Then we have diseases that have demyelination of the peripheral nervous system, and this is Guillain-Barré syndrome. It's a radiculopathy, pathology in the nerve roots, and peripheral neuropathy as well, so it's a pathology in the peripheral nerve. Today's topic is Myasthenia Gravis and Lambert-Eaton Myasthenic Syndrome, both of which are problems in the neuromuscular junction. The difference is that Lambert-Eaton Myasthenic Syndrome affects the presynaptic neuron, whereas Myasthenia Gravis affects the postsynaptic skeletal muscle. Lambert-Eaton does not have to be skeletal muscles only. It could be the nerves that supply anything. But Myasthenia Gravis only affects skeletal muscles. If you want to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. Back to normal physiology. This is a nerve fiber. This is the terminal part of the axon, or the axon terminalis. In order for this neuron to get excited, sodium has to enter, hashtag sodium influx, hashtag depolarization. Then you depolarize the neuron, which means you activate it, until you activate the calcium channels here. Calcium will enter into the cell. Calcium is the hero of contraction. Calcium, contraction of the vesicle. The vesicle will rupture by exocytosis to release the acetylcholine in the synapse. Then acetylcholine binds onto the skeletal muscle receptor. In this case, it's nicotinic sub-M receptor or acetylcholine receptor. After this, the skeletal muscle will generate its own action potential and contract. We have two autoimmune diseases. One is affecting presynaptic, one is affecting the postsynaptic. The one that's affecting the presynaptic voltage-gated calcium channel is Lambert-Eaton Myasthenic Syndrome. But the disease that affects the postsynaptic, nicotinic sub-M acetylcholine receptors on skeletal muscles only, is Myasthenia Gravis. Please pay attention. Where do we find the nicotinic sub-M acetylcholine receptor? You only find it in skeletal muscles. Therefore, Myasthenia Gravis only causes problems in skeletal muscles, namely skeletal muscle weakness. However, where do we find the voltage-gated calcium channels? In many nerves. Which ones are attacked in Lambert-Eaton? A special type of calcium channels known as the PQ calcium channel. We found these channels not only in the nerves that supply skeletal muscles, but in the nerves that supply smooth muscles as well. We found them in somatic nerves and we found them in autonomic nerves. So therefore, Lambert-Eaton Myasthenic Syndrome will cause skeletal muscle problem and smooth muscle problem or autonomic symptoms. Myasthenia gravis is a somatic disease, but Lambert-Eaton affects somatic and autonomic. Lambert-Eaton affects the presynaptic voltage-gated calcium channels, namely the PQ calcium channels, whereas myasthenia gravis affects the nicotinic sub-M acetylcholine receptor. How do they affect them? By means of nasty autoantibodies. These are autoimmune diseases. Here is a short list of the types of calcium channels based on the difference in their alpha subunits. The ones that are affected in Lambert-Eaton are the PQ type, which are found in the Purkinje cells of the cerebellum and presynaptic axon knobs. This is what we're talking about. If I have a disease in the brain, it's called encephalopathy. If I have inflammation of the brain, it's encephalitis. If I have inflammation of the meninges that cover the brain and the spinal cord, it's called meningitis. If I have a pathology in the spinal cord, it's called myelopathy, not encephalopathy. If I have a problem in the nerve roots, as the nerve exits or enters the spinal cord, it's radiculopathy. Pathology in the peripheral nerve is named peripheral neuropathy. Pathology in the muscle is called myopathy. None of these are affected in myasthenia or Lambert-Eaton because the diseases affect neuromuscular junction. Lambert-Eaton is presynaptic, myasthenia is postsynaptic. If you want to see more videos like this in the future, please drop a brain emoji in the comments. This is the upper motor neuron. It's not affected in myasthenia or Lambert-Eaton. This is the lower motor neuron. It's not affected in myasthenia or Lambert-Eaton, except the last part. The axon knob is affected in Lambert-Eaton myasthenic syndrome. And then when you draw the muscle, the skeletal muscle is affected in myasthenia gravis. There are many types of nerve fibers. There are somatic nerve fibers that supply skeletal muscles. There are autonomic nerve fibers, whether parasympathetic or sympathetic, that supply smooth muscles rather than skeletal muscles. Myasthenia gravis is only gonna hit the skeletal muscles, nicotinic sub-M receptor, which is the acetylcholine receptor. However, Lambert-Eaton myasthenic syndrome will destroy these fibers that supply skeletal muscles and these fibers that supply smooth muscles. And that's why myasthenia gravis only has somatic symptoms, motor weakness in skeletal muscle, but Lambert-Eaton myasthenic syndrome has somatic motor symptoms and autonomic symptoms. Let's compare and contrast myasthenia with Lambert-Eaton. Myasthenia, what's going on? Autoimmune disease, where we have nasty autoantibodies against the post-synaptic acetylcholine receptor, which is nicotinic sub-M. But some patients do not have this type of antibodies. Instead, they have another type of antibodies, and these are autoantibodies against muscle-specific tyrosine kinase or anti-MuSK. Patients who have anti-MuSK have some unique features of myasthenia. They tend to have more bulbar motor symptoms. Again, what is the bulb? The bulb is the brainstem. Bulbar motor symptoms are the muscles supplied by the cranial nerves that originate from the brainstem. Remember that cranial nerves 3 and 4 come from the midbrain. 5, 6, 7, and 8 come from the pons. 9, 10, 11, 12 come from the medulla. And all of these are going to supply muscles in the face and the neck. So these are the muscles that get motor symptoms, and this is what we mean by bulbar motor symptoms, such as diplopia, such as ptosis, such as dysphagia, such as dysarthria. Patients with anti-MuSK tend to have more proximal muscle atrophy when you compare them to the anti-acetylcholine receptor antibody counterparts. Patients who have anti-MuSK tend to lack response to pyristigmine because most patients with myasthenia will improve if you give them pyristigmine. Not these patients. These patients with anti-MuSK will not improve if you give them pyristigmine, and sometimes they can even deteriorate when you give them pyristigmine. Most patients with myasthenia gravis have the post-synaptic acetylcholine receptor antibody, which is only post-synaptic. But patients with anti-MuSK can be affected presynaptically and postsynaptically. Patients who have antibodies against the postsynaptic acetylcholine receptor tend to have thymoma or thymic hyperplasia. But this is not the case in patients who have anti-MuSK antibodies. How about Lambert-Eaton Myasthenic Syndrome? We have autoantibodies against presynaptic, not postsynaptic. Voltage-gated PQ calcium channels, we find them in somatic nerves and autonomic nerves as well. There are two types of Lambert-Eaton, those who have cancer with it, and that's the most common, and those patients who do not have cancer with that. And that's why many oncologists describe Lambert-Eaton Myasthenic Syndrome as a paraneoplastic syndrome, a syndrome that happens in parallel to cancer. Let's talk about myasthenia demographics. The most common neuromuscular junction disorder is myasthenia. It is way more common than Lambert-Eaton. In adults, most myasthenia patients are females, usually of childbearing age. Myasthenia is associated with HLA, DR2, and DR3. As for Lambert-Eaton, most patients are older and mostly males. And most patients with Lambert-Eaton myasthenic syndrome have some form of cancer, usually small cell lung cancer. And about 20% of patients with Lambert-Eaton myasthenic syndrome, which is an autoimmune disease, have another autoimmune disease. As Warren Buffett used to say, quote, "There is seldom one cockroach in the kitchen," unquote. So if I have one autoimmune disease, I am more likely than the general population to have another autoimmune disease. Let's talk about the clinical picture, first of myasthenia and then of Lambert-Eaton. Myasthenia gravis symptoms: double vision, muscle weakness that gets worse the more I use it. So with repetitive movements, the weakness gets worse. I am also tired all the time. Signs: fatigable weakness, same thing, muscle weakness that worsens with use and improves with rest. The muscle weakness affects the muscles of the eyelid, so I get ptosis or droopy eyelids. Weakness of the extraocular muscles, causing double vision. Weakness of the proximal muscles, such as the neck muscles. Tongue weakness can also happen. Distal weakness can happen, but it's not as common as the proximal muscle weakness. The diaphragm can get weak. Why? Because the diaphragm is a skeletal muscle supplied by a somatic nerve, known as the phrenic nerve. What is the root value of the phrenic nerve? It is C345, keep the diaphragm alive. C345, keep the diaphragm alive. Bulbar symptoms are symptoms in the face and the neck because of problems in the cranial nerves that emerge from the brainstem, include diplopia, dysarthria, dysphagia, and more. Pay attention. Myasthenia gravis has normal deep tendon reflexes. Reflexes in general are normal. Normal sensations, because only the skeletal muscles, motor, are affected. Normal coordination, because the cerebellum is healthy. And no autonomic symptoms, because myasthenia only targets the receptors on skeletal muscles and not smooth muscles. Let's compare that with Lambert-Eaton myasthenic syndrome. Symptoms: post-exercise facilitation. What does that mean? The muscle weakness improves with brief exercise. Just like myasthenia, it's more proximal than distal. The most common site is the proximal lower limb, so the patient complains of difficulty walking upstairs and difficulty rising from a chair because the hip and thigh muscles are weak. Unlike myasthenia gravis, Lambert-Eaton has autonomic symptoms such as dry eyes, xerophthalmia, dry mouth, xerostomia, blurry vision, orthostatic hypotension, which means when I stand up suddenly, my blood pressure drops and my heart rate increases beyond a certain threshold. And erectile dysfunction can happen in patients with Lambert-Eaton. Clinical signs include the muscle is getting weaker, deep tendon reflexes are diminishing, but they improve by repeated tapping of the tendon. So if you are checking the patellar tendon reflex, the first tap will give you a very weak response. But if you keep tapping the same tendon again and again and again, you will notice that the patient's reflex is getting better and better and better. And this is what we call post-exercise facilitation. Myasthenia gravis can affect the muscles of the eye and the eyelid, and myasthenia can have bulbar motor weakness. But this is not the case with Lambert-Eaton. Most patients with Lambert-Eaton do not have ocular symptoms or bulbar muscle weakness. There are clinical variants for myasthenia and for Lambert-Eaton. For myasthenia, there is a myasthenia gravis that affects the eye. There is a myasthenia gravis that's early onset generalized, another that's late onset generalized, another that's associated with thymoma or thymic hyperplasia, another that is generalized with anti-MuSK antibodies, and another with no acetylcholine receptor antibodies. As for the clinical variants of Lambert-Eaton myasthenic syndrome, we have paraneoplastic, and non-paraneoplastic. The most common is the paraneoplastic. Most of these patients have cancer. Most of the time it is lung cancer. Most of the time it's small cell lung cancer. There are some fun facts that you need to know about small cell lung cancer. Number 1, it's associated with Lambert-Eaton Myasthenic Syndrome. Number 2, it can secrete lots of ADH, that's another paraneoplastic syndrome, which causes SIADH, or syndrome of inappropriate ADH secretion, which can lead to hyponatremia. Let me tell you something. Any patient on your exam who has a serum sodium concentration less than 125 milliequivalents per liter has small cell lung cancer until proven otherwise. Next, small cell lung cancer can secrete ACTH, that's a third paraneoplastic syndrome, which will increase cortisol, which will increase blood sugar, and can also increase blood pressure due to salt and water retention. If you want to learn more about ACTH and cortisol, please refer to my endocrinology playlist. To learn more about hyponatremia and hypernatremia, refer to my fluids and electrolytes playlist. How can we diagnose myasthenia and how can we diagnose Lambert-Eaton? To diagnose myasthenia, clinical signs and symptoms, challenge test with idrophonium. When you give idrophonium, the patient improves. Why? Because idrophonium inhibits the inhibitor of acetylcholine. It inhibits the acetylcholinesterase. And when you inhibit the inhibitor of acetylcholine, acetylcholine will improve and increase in the synapse. And just like competitive inhibition, acetylcholine can overcome the nasty antibodies and beat them to the target, which is the acetylcholine receptor, so the patient's symptoms improve because the muscle contracts. You can also use the ice pack test. You can notice the droopy eyelids of the patient, and then after you apply ice, the drooping improves. Remember that repetitive nerve stimulation will make myasthenia worse by decreasing the muscle action potential, and we can find this in EMG or nerve stimulation test. EMG is the most sensitive test for myasthenia gravis. Serum antibodies can reveal anti-acetylcholine receptor antibodies or anti-MuSK antibodies. Remember that the diaphragm is a skeletal muscle that has an acetylcholine receptor, so make sure that the patient is okay by ordering respiratory function tests like spirometry and pay close attention to the forced vital capacity. CT scan of the chest to look for thymoma because many patients with myasthenia have thymoma. And if you remove the thymoma, the myasthenia improves. How can I diagnose Lambert-Eaton? Clinically, electromyography and nerve conduction studies, deterioration at first, but after brief, robust exercise, the patient improves tremendously. And this is what we call post-exercise facilitation. If you want to learn more about EMG, I have a special video on this topic in my Physiology playlist. Myasthenia patients have thymoma, but Lambert-Eaton Myasthenic Syndrome patients have small cell lung cancer, so you do a CT scan of the chest. Look for serum antibodies against presynaptic voltage-gated PQ calcium channels. Why do acetylcholinesterase inhibitors help patients with myasthenia? Because they inhibit the inhibitor. They destroy the destroyer. Who's the destroyer? Acetylcholinesterase enzyme. And they destroy the acetylcholinesterase enzyme, so therefore no one is going to destroy acetylcholine. Acetylcholine will become abundant and will beat the antibodies to the target receptor. So, medications like physostigmine, neostigmine, etc. are beneficial to patients with myasthenia. The one that we use the most is pyridostigmine. Remember how opioids work? Yeah, they are potassium channel openers, and when you open potassium channels, the positive electrolyte escapes the neuron, leaving the inside of the neuron more negative or hyperpolarized or inactivated. And since the nerve is inactivated, therefore the calcium channel will be inactivated, calcium will never enter, the neurotransmitter will never be released, and this is how opioids kill the pain. Here is the exact opposite of opioids. It's called amifampridine. Instead of opening potassium channels, it closes potassium channels, increasing the potassium inside the neuron. When the positive ion accumulates inside, we call this depolarization, which is activation. If the nerve is active, the calcium channel is active, meaning open, calcium will enter and it will release the neurotransmitter, so amifampridine can improve the symptoms of Lambert-Eaton Myasthenic Syndrome by boosting the level of calcium inside the neuron. How can we treat myasthenia gravis? Try to avoid these medications because they make things worse. Avoid aminoglycosides, beta blockers, class 1 antiarrhythmics, and quinolone antibiotics. Give acetylcholinesterase inhibitors like pyristigmine. Since this is an autoimmune disease, inhibit the immune system by giving immunosuppressants such as prednisone. You can throw a stick to the dog. Who is the stick? IVIG is the stick. Who is the dog? The antibodies are the dogs. Now the dogs will be busy attacking the IVIG and leaving the acetylcholine receptor alone. So the muscle will contract and the patient will improve. You can also remove the patient's plasma, which contains the nasty antibodies, wash it, and return it back to the patient clean and without any antibodies. Be careful, take care of your diaphragm, and provide mechanical ventilation if the patient needs it. If the patient has thymoma, you remove it. How do we treat Lambert-Eaton Myasthenic Syndrome? Avoid the same medications. Also avoid succinylcholine and tubercularine because they are neuromuscular blockers. If there is a lung cancer with Lambert-Eaton, you treat it. Similarly, since it's an autoimmune disease, immunosuppressants, IVIG or plasma exchange, and the famous amifampridine. Let's summarize myasthenia gravis in 1 minute. The patient is 20 to 40-year-old female with HLA-DR2 or DR3. Symptoms include fatigable weakness that gets worse with the repetitive use of the muscle. Diplopia is common, ptosis is common, dysphagia and dysarthria can happen. Proximal muscle weakness is more common than distal muscle weakness. Deep tender reflexes are normal, sensations are normal, coordination is normal, and no autonomic symptoms exist in myasthenia. How can we diagnose myasthenia clinically? Look for antibodies in the serum, whether anti-acetylcholine receptor antibodies or anti-MuSK antibodies. Electromyography. Challenge test with hydrophonium test. You can also use the ice pack test. CT scan of the chest to look for thymoma. You treat myasthenia with anti-cholinesterase inhibitors like pyristigmine. With immunosuppressants, IVIG or plasma exchange. If there is thymoma, you remove it. Lambert-Eaton Myasthenic Syndrome in 1 minute. Your typical patient is 50 to 60-year-old male with small cell lung cancer, muscle weakness that improves with exercise. We call this post-exercise facilitation. Proximal muscle weakness is more common. Lower limb weakness is more common than the upper limb. Autonomic symptoms can happen, including dry eye, dry mouth, orthostasis, and sexual dysfunction. Physical exam findings include weak muscles, absent or weak reflexes, but if you keep tapping the same tendon, the reflexes improve. You diagnose Lambert-Eaton clinically, EMG and nerve conduction studies, look for post-exercise facilitation, look for antibodies in the blood against the calcium channels, CT scan of the chest to look for the lung cancer. You treat similarly with immunosuppressants, IVIG, plasma exchange. You manage the lung cancer, and you can give amifampridine. Now to the best part of the lecture. Here is a beautiful comparison table between Lambert-Eaton and myasthenia. Lambert-Eaton is paraneoplastic. It's associated with small cell lung cancer, but myasthenia gravis is not associated with lung cancer. It is associated with thymoma in some cases. Both of the diseases are autoimmune. In Lambert-Eaton, the antibodies are attacking the presynaptic calcium channels, but in myasthenia gravis, the antibodies are attacking the postsynaptic acetylcholine receptors or nicotinic sub-M receptors. The muscle weakness in Lambert-Eaton improves with brief exercise, but in myasthenia it worsens with repetitive movement. So we can say that Lambert-Eaton myasthenic syndrome patient is happier in the evening because the more you move the muscles, the more they get better. We can argue that myasthenia gravis is miserable in the evening because the more you use them, the worse they get. Lambert-Eaton myasthenic syndrome is less likely to have bulbar weakness such as ptosis, diplopia, dysphagia, dysarthria, but myasthenia gravis is more likely to have bulbar weakness. Autonomic symptoms only show up in Lambert-Eaton but not in myasthenia, so look for orthostasis, erectile dysfunction, dry mouth, constipation, etc. in Lambert-Eaton. Deep tendon reflexes are diminished in Lambert-Eaton, but they are normal in myasthenia gravis because the reflex arc is intact. What happens when you give hydrophonium challenge? Lambert-Eaton, no difference. Myasthenia improves. Associations. Lambert-Eaton is associated with small cell lung cancer, but myasthenia is associated with thymoma or thymic hyperplasia. How do you diagnose Lambert-Eaton? Electromyography, antibodies in the serum against calcium channels, and CT scan to look for small cell lung cancer. Myasthenia gravis, you do EMG, challenge test with hydrophonium or the ice pack test, look for serum antibodies against acetylcholine receptor, and CT scan of the chest or upper chest to be specific to look for thymoma. Treatment of Lambert-Eaton is to manage the lung cancer, immunosuppressants IVIG plasma exchange, and amifampridine. But of myasthenia, acetylcholinesterase inhibitor, pyristigmine, immunosuppressants IVIG plasma exchange, and remove the thymoma. Now let's answer the question of the previous video. We have a 35-year-old male complaining of dyspnea, difficulty ambulating, tingling and numbness, and blurry vision. The patient says, "Doc, I cannot chew a cracker. I feel my mouth is so dry." Sexual history is relevant for erectile dysfunction. He mentions that he is always constipated in spite of the fact that his diet is rich in fiber. 7 years ago, he worked part-time in a coal mine for just 2 weeks. When asked about symptoms that bothers him the most, he says difficulty breathing. Physical exam is significant for warm, flushed face with no sweating. Decreased strength of the arms and thighs bilaterally. The table tilt test is positive. You order pulmonary function test to find the following: reduced, high, reduced, normal. What is this? Please pause the video. Based on the respiratory function test, this patient has restrictive lung disease, not obstructive but restrictive. Now, is it intrinsic restrictive or extrinsic restrictive? Since the DLCO is normal, it is extrinsic restrictive, meaning do not blame it on the lung because it's not intrinsic. It's not the lung's fault. So it has to be the fault of something else, such as the diaphragm, the phrenic nerve, or the chest wall. This patient has erectile dysfunction, constipation, dry mouth. All of these are autonomic symptoms. The patient has motor weakness as well, and the patient has Horner syndrome, ptosis, meiosis, and hydrosis. Put all the facts together, this patient has Lambert-Eaton Myasthenic Syndrome together with small cell lung cancer. First question, which of the following is the likely underlying pathophysiological mechanism of this presentation? Pause the video and try to answer this yourself. The correct answer is B, anti-voltage-gated calcium channel antibodies on the presynaptic neuron. Next, which of the following should be done for screening purposes? Well, the patient probably has lung cancer, so I'm doing CT scan of the chest and abdomen. Third, previous screening tests were negative. Which of the following is the best management option? Which of the following is the best management option? I'm going to go with the one that has plasmapheresis and immunotherapy, even though the pyristigmine is not going to help that much, but this is the best option. I've asked you about this question before. Please pause the video and let me know the answers in the comments. To learn about adrenergic pharmacology, cholinergic pharmacology, the alpha receptors, the beta receptors, the muscarinics, the nicotinics, download my autonomic pharmacology course at medicosisperfectionalis.com. It comes with videos, notes, and cases. To learn about cardiac arrhythmias, strokes, myocardial infarction, acute respiratory distress syndrome, acute limb ischemia, drowning, toxidromes, and much more, download my emergency medicine high yields course at medicosisperfectionalis.com. To learn about anti-epileptics, antidepressants, antipsychotics, anti-Parkinsonian medications, anesthetics, opioids, stimulants, sedatives, and hypnotics, download my CNS pharmacology course at medicosisperfectionalis.com. If you found these videos to be helpful, please consider supporting my channel by buying me a coffee. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel if you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.